Hello, everyone. Thank you for listening to the Code Life podcast. The Code Life podcast provides a forum for discussions on healthcare issues and challenges with specialists from diverse backgrounds. I'm Sylvie Riendo, and I will be your host for this very interesting episode. Today, I have the privilege of interviewing Dr. David S. Mulder. Born in Eston, Saskatchewan, Canada, Dr. Mulder is renowned for many things. One is for his association with the Canadiens de Montréal organization since 1963 as chief surgeon. Formerly chief surgeon at the Montreal General Hospital, chairman of the Department of Surgery and senior director thoracic surgery at McGill University, he is a pioneer in traumatology. In fact, he is one of the reasons the Montreal General Hospital is ranked among the top trauma centers in Quebec. Having been fully committed to this field for many years, he has been broadly recognized for his role in developing a province-wide trauma system in Quebec. The Montreal General Hospital even named its trauma center after him. Hello, Dr. Mulder. Thank you for being with us today.
Good to be here.
The public mostly knows you as the surgeon-in-chief for the Montreal Canadiens, a position that you've filled for almost 50 years now. How did your work with the Montreal Canadiens start?
Well, it started when I began my career in surgery at the Montreal General Hospital in July of 1963. And in September of 63, Dr. Kinnear had just taken over as medical director of the Montreal Canadiens and also the care of the Montreal Junior Canadiens. And he needed some help to cover the games at the Old Forum, looking after the Montreal Junior Canadiens. So he asked me to organize a team of surgical residents who could attend every game. They were Sunday afternoon, as you remember, and they were very exciting for me because I loved hockey, and this was an incredible experience. So that's how we got started.
Because you were yourself a hockey player.
Yes, I played hockey, amateur hockey all of my life, and I played hockey at university. I loved hockey, and as I probably explained, when you're in Saskatchewan, you cheered either for the Toronto Maple Leafs or the Montreal Canadiens. And for some reason, I had been aligned with the Montreal Canadiens, and my hero in hockey was Jean Beliveau. And you can imagine my delight. One of the first games I covered at the Old Forum, Jean Beliveau was in attendance at a Junior Canadiens game. And he actually sat beside me, and, I almost fainted. It was such an experience.
Yeah, having your hero beside you kind of has that effect.
And, of course, it established a long-term friendship. And,
you've been with the Montreal Canadiens for many years, assisting to almost every match.
Right.
So is there a specific moment you recall being especially concerned for the health and well-being of one of the players?
Oh, no question. The night I was the most frightened in my whole life was the afternoon that Trent McCleary got hit in the larynx, or the voice box, with the puck. It was a slap shot, and it fractured the larynx and basically blocked his airway. And so we had to institute measures to try and reduce the fracture and get his airway open before we got him to the hospital. And my worry that he was going to die on the ice or in our hands on the way to the hospital. We were able to use a maneuver called a jaw thrust, which opened the airway and allowed us to get him to the hospital. So we had to get him to the hospital as quickly as we could, and we were very fortunate. It was a Sunday afternoon, and so the ambulance was able to get to the hospital very quickly. Time from injury to the operating room was 17 or 18 minutes, and this clearly saved his life. We didn't stop in the emergency room. We didn't stop for anything. We phoned ahead, and we had the anesthesiologist meet us in the corridor at the 8th floor elevator, which secured his airway, and then we could do a tracheostomy. But we moved him right from the elevator to the operating room table, and it was the only time I've ever operated on anybody with their skates on. And we didn't have time to even get his equipment off. But it clearly reinforces the variable of time from injury to definitive care.
Absolutely.
Being life-saving in this situation.
Yeah.
Yeah. This is clearly the most frightening episode that I've had. And it changed the way we manage injuries in the whole NHL. Now the trauma doctors have to be behind the bench 25 feet away from the medical clinic. So it altered practice throughout the whole NHL.
Well, sure. Talking about that, how would you compare sports medicine from when you first started until now?
Well, it's changed drastically. When I first started with the junior Canadians, you have to remember nobody wore a helmet, nobody wore a face mask, and the rules and regulations were not so clear as they are now. But we had many concussions. We had lost 2 or 3 eyes from puck injury. We had many lacerations. Every game we sutured up several players. Now those things have all changed. There hasn't been an eye injury in hockey, in amateur hockey, because everybody wears a full face mask. So it's changed drastically. And in fact, sports medicine has become a science of its own. We've established a department at McGill University. And so things have changed for the better in a drastic way.
So how did you develop your interest for traumatology?
Well, when I came to Montreal, the first person I met was Dr. Rock Robertson, who was chair of surgery here. He later went on to become principal at McGill. And he was in charge of the surgical training program. And he insisted that each surgical resident have an area that they would call their special area of interest. And he suggested to me that I should become interested in trauma because he felt it was poorly managed in Canada and in Quebec. And he suggested we had to use some of the lessons that he learned during the war. He was a veteran of the Second World War. And he said in the wartime they learned that the most important factor in trauma was the time from injury to definitive treatment. And he said they learned in the war that if you stopped at a hospital that wasn't able to treat the patient, well, everybody thought it was good. It actually delayed the final treatment. So he suggested I look at that in Quebec and see how we measured up to the rest of the world. And so we began gathering data. And then when I went away to train in Iowa, we were situated at the University of Iowa, was situated on a highway. And we were inundated with major trauma from an interstate. And so that solidified my interest in trauma. And the interesting thing was the trauma to the airway, which is what Trent McCleary suffered from. So you can see how the two, the hockey injuries and the trauma profile are very closely related. So then when I came back on staff here, my mentor then was Dr. Fraser Gerd. And his sole interest in life was trauma. And he encouraged me to take a leadership role. We didn't have an organized trauma service here. So we set that up and organized an ICU. And then we began to study our results in Quebec. And we found that when we compared ourselves to the equivalent centers in the United States, if we had a very serious injury, we measured them on an injury severity scale. And if we had the equivalent injury here compared to a big center in the United States, our mortality was 50% and theirs was 10%.
Wow.
So we presented this information, and Dr. Gerd said, well, I don't want you to present it anywhere because I'm embarrassed how badly we're doing. So we have to take a back route and see if we can change this. So we recruited a surgeon from the United States, Don Trunke, and he came with me to meet the then Minister of Health, Marc Yvan Cote. Mm-hmm. We met in Quebec City in a bar, and we mapped out a plan of regionalizing trauma care. It's nothing new. It was similar to what was already in the United States, where you have a level 1, 2, and 3 trauma centers, and the most seriously injured come right away to the level 1 trauma center rather than going to the nearest hospital, which everybody thought was the best idea then. Mm-hmm. And so then he bought the idea and implemented it in the early 90s, 93. Mm-hmm. And then when we did our study several years later, we found that the mortality rate had gone from 50% down to 13 or 14%, and now it's continued to come down. And it's a program that's been accepted all over the world. And the results we presented our paper at the American Society for the Surgery of Trauma, and they were amazed at it really proved the concept of the value of regionalizing trauma care and the level 1 trauma centers.
Mm-hmm. So how did you, went into this reform? You had to convince a lot of people, or, the health ministry was already convinced. So you found it difficult?
But I think the important thing that I learned from Dr. Gerd is it's hard to convince people unless you have data. Mm-hmm. So the study we did, which was embarrassing to us in terms of our results, proved to be the most important thing in terms of changing people's mind and convincing others, including the Minister of Health and our own hospital, and maybe our own profession, because I was very unpopular at the time, because taking trauma away from other hospitals, other centers, people were very angry with me, and yet it was the right thing to do.
What has changed, and what are we doing differently now that the system is in place?
Well, I guess the single most important thing is we've regionalized trauma care and we've organized pre-hospital care. And we have set criteria about which patients need to go to a level 1 trauma center right away. And these are all well known now by our pre-hospital crews. And that has reduced the time. Remember Dr. Robertson's point that time is the most important variable. So that has reduced the time from injury to definitive care. And to me, that's the most important factor.
Yeah, because, for example, right now, someone who has, let's say, a car accident in Saint-Jean-sur-les-Richelieu, for example, and has serious injuries, that would require trauma. So what will happen is that person will be taken right away to the Montreal General Hospital.
Right away to a level 1 trauma center.
Exactly. Instead of going to the local hospital, which may not have the team or the
And we've learned from the United States and from other Canadian provinces that if somebody with that magnitude of injury goes to a smaller center and it has some delay there, and then to a level 1, that the mortality rate is 25% higher. Mm-hmm. So that has played an enormous role. And the thing that we haven't done well, I think, is prove to the government that this is financially a very good investment, that it reduces ultimate costs to society.
Now there are 3 level 1 trauma centers in Quebec.
Yes.
We have the Montreal General Hospital, Sacré-Cœur.
So we have 2 on the island of Montreal. Mm-hmm.
And one is in Quebec.
Laval, in Quebec City.
Laval University, but in Quebec City. All right. And recently, the Quebec Health Minister launched a pilot project for a helicopter ambulance service. It's, I believe, with Sacré-Cœur Hospital. And you've been quite involved in persuading the Quebec government of the necessity to have a helicopter service. Can you explain why?
Well, I'm very, very proud of the Minister of Health that he's taken on this as a pilot project and starting it right away at Sacré-Cœur, because they have a heliport. So it will test the value of this system, and we can start immediately. We don't have a heliport at the Montreal General Hospital, but the minister has promised that once we establish that we'll be included. Why is that important? Well, yesterday I was out at Brossard at the Canadians training facility, and I drove back across the Champlain Bridge behind an ambulance. Took us 45 minutes to get across the Champlain Bridge. Mm-hmm. That's why we need a helicopter.
For sure.
We need a helicopter to reduce the variable of time from injury to definitive care. And when we all saw the tragedy in Humboldt, it bothered me immensely that in a little province like Saskatchewan, they had 2 helicopters at the scene of a bus crash. I began to worry if Quebec had a school bus crash at Hemingford or somewhere rural Quebec, could we do the same thing? Could we? And I realized right away that we couldn't. And that's something that we need for the entire province of Quebec, we have to have that facility. Exactly. And I have to commend the Minister of Health that for his efforts in making this happen. And he accepted he bought into it, and there are financial things that he has to overcome. But you have to give him credit for making this first step and getting it on the way.
Mm-hmm, because Ontario has such a service.
And every province in Canada except Quebec,
Mm-hmm.
every major city in North America except Montreal has a helicopter program. So it's important for trauma, very important, but it's also important for obstetrics, for cardiac disease, for stroke. Perhaps the biggest advantage that has been proven in Saskatchewan is they have a stroke center in Regina and Saskatoon. And so when somebody has a stroke in a periphery, they're immediately transferred to a stroke center, and they have the very best care, and it's reduced the death rate, and it's reduced the morbidity, the paralysis after a stroke. So it's a vital part of our healthcare network, getting patients to the right hospital at the right time.
Absolutely. And, we're talking about the government making improvement, but there still must be room, for improvement in our health system. So what are the priority areas of investment, in your opinion?
Well, that's a good question. And I have we've talked with the health minister at times about this, but for me now, there are so many changes occurring in healthcare delivery, high-tech, aging population, improvement in trauma care, improvement in cancer care. So I think we have to look at a whole new way of financing healthcare in Quebec so that the financial support or the money follows the complexity of care of the patient. So if you have an advanced cancer, you're better off being treated in one of the university centers where they're doing research and developing new drugs, developing and so I think in the past our budgets have been historical and block budgets, and this needs to change immediately. And then regionalization of care, which is the trauma model, which I think has a ripple effect on the whole hospital. It makes the whole hospital better. The ICU is better. The emergency room is better. The pre-hospital transport is better. So this is a model that we have to apply across the province to every disease, but that will mean changes in education of our medical students and how because that'll change the distribution of patients in our level 1 centers. So I think it's an enormous opportunity. And the minister is also aware of that and is working on an approach along those lines.
Mm-hmm. And, with all the changes we are facing in our healthcare system, what advice would you give to future doctors?
I wish I were just starting. There are so many golden opportunities. I think being a physician, and particularly being a surgeon, is perhaps the most exciting career opportunity there is. I wouldn't change anything in terms of my career. It's been an amazing journey and I've had lots of luck in meeting Dr. Kinnear, Dr. Robertson. All these people have been mentors and made my life what it is. But I would strongly encourage any young person that it's the ultimate career.
And right now, is there a specific field, like a new field in medicine? You'd say, if I'd be starting my studies, medical studies, that's where I'd go.
Well, yeah, I think one of the most exciting things now is artificial intelligence. Mm-hmm. And it's going to have an enormous impact on medicine and the information technology. I mean, I'm way behind in that. I have to have my grandchildren help me with the computers so it doesn't freeze and so on. But I think the combination of artificial intelligence and computer information technology is going to make us even better physicians. The other thing it's going to do is allow us to keep much better records, to determine our results, and to have data. And for me, the thing that changed the trauma scene in Quebec was that we had the data to prove that we weren't doing as well. And that's where I think the future of artificial intelligence and information technology lies.
So you feel like with your experience at some point, with having to take certain decisions on, let's say, a disease or accident, having more information about it, more data would have been very helpful.
Absolutely. There's no question in my mind that that's going to be so important in the future. Medical data, financial data, it'll allow us to maximize the value in our healthcare system for the dollars we spend, which is critical because healthcare costs are rising at an exponential rate. It's going to be very important.
Absolutely. Well, thank you so much for your time today, Dr. Mulder. Such a great career, very inspiring for all of us.
You're very welcome.
It was a pleasure interviewing you, and I'm sure a lot of people learned many things about you. So thank you all for listening to the Code Life podcast. For more information, I invite you to visit our website, codelife.ca. Until next time.